modified Anderson's procedure for treatment of infantile nystagmus syndrome. By definition, nystagmus is a rhythmic, involuntary oscillation of one or both eyes. It could be congenital, which is the infantile nystagmus syndrome, or acquired. And the congenital one can be due to a sensory defect where there is a defect in vision, or due to a motor defect where the patient can see even 6/6, but there is a problem with the extraocular muscles of the patient. Or it could be acquired usually due to a neurological cause. Null zone, the amplitude and frequency of nystagmus decrease or disappear in one gaze position. And the visual acuity improves in this position. So the patient acquires an anomalous head posture to move the eyes in the null zone to improve vision. For example, if the null zone is to the right, the patient has a left face turn, so the eyes go to the right where the nystagmus is least and the vision is best. These two children are acquiring a right face turn to move the eyes into the left gaze where the null zone is. This boy is acquiring a left face turn to move the eyes into right gaze where the null zone is. In this position, the nystagmus is almost absent, but if we straighten the head, the nystagmus starts to appear, and if we move the head in the opposite direction, and if we move the head in the opposite direction, the nystagmus gets worse. بس هو ما جاش الفيديو هو في opposite direction. Okay, so treatment of nystagmus, the aim is to improve vision, to decrease oscillopsia, but oscillopsia is not present in infantile nystagmus syndrome, it's only present in acquired forms of nystagmus. And to shift the null zone towards the primary position to straighten the head. The surgical treatment of nystagmus depends on whether nystagmus is associated with an abnormal head posture or a gaze null, or it's not associated with an abnormal head posture or no gaze null. This child has a right face turn to move the eyes into the null zone, which is to the left. So the surgical treatment in this case is to surgically move the eyes into the direction of the head to move the null zone to the primary position instead of eccentric gaze. يعني احنا هنحرك العينتين ناحيه الفيس تيرن بتاع العيان. ليه احنا عايزين ننقل النال زون من الاكسنتريك بوزيشن دي للبرايمري بوزيشن؟ يعني كأن الرايت اي as if it's an esotropic eye، فهنعمل recession للميديال resection للlateral rectus، والleft eye as if it's an exotropic eye so we will recess the lateral and resect the medial. فلما عملنا كده حركنا العينين للبرايمري بوزيشن وحركنا النال زون للبرايمري بوزيشن بحيث ان هو ما يحتاجش يعمل an abnormal head posture. في كذا procedure to perform this. The first one is the Kassem procedure where we recess one pair of yoke muscles and resect the other pair of yoke muscles with doses according to the degree of the face turn. يعني in this patient, the right eye, as if it's an esotropic eye, we recess the medial and resect the lateral. Left eye, we recess the lateral and resect the medial. يبقى yoke muscles اللي هي right medial rectus وال left lateral rectus are recessed, while other yoke muscles اللي هي right lateral rectus وال left medial rectus are resected. ده التيبل اللي بيعملوا على أساسه الكاسم باوند procedure is according to the degree of face turn. أول حاجة if it's less than 20 degrees بنعمل الكلاسيك اللي هو 5 6 7 8 5 for medial rectus recession, 6 for medial rectus resection, 7 lateral rectus recession, and 8 lateral rectus resection. يعني دايما الميديال الأرقام الأقل والريسيشن الأرقام الأقل. ولو الفيس تيرن أكتر هي increase الدوزز دي لحد لو بنزود up to 60% of the 5 6 7 8. بعد كده في حاجة تانية اللي هو الأندرسون's procedure اللي هم شالوا الريسكشنز. They just do the recessions without performing any resections. So it's recession of one pair of yoke muscles only. For example, in this case, with the right face turn, we recess the right medial rectus and the left lateral rectus. ما بنعملش أي resections عشان نحرك العينتين للنال زون يبقى في primary position. And the graded Anderson procedure, the amount of recession is determined by the degree of face turn. based on the Parkes table for Kassem procedure disregarding the resection component. يعني نفس الجدول القديم اللي كانوا بيعملوه في الأندرسون كاستنباوم بيستخدموه هو بس بيشيلوا الريسكشنز، بيعملوا بس الريسكشنز اللي في الجدول. This child had a graded Anderson procedure. This is the preoperative picture with the right face turn, and postoperatively the child acquired a straight head. But not all patients are that much corrected. في حاجة اللي هي tendon enthesis اللي هي tendinoscleral area of extraocular muscle tendon، يعني مكان ما التندون بيمسك في السكليرا. هيرتل عمل study على neuroanatomy of the extraocular muscle tendon enthesis in macaque monkeys, normal humans, and patients with congenital nystagmus. He examined the tendinoscleral area بتاعت التندون ولقى in the enthesial neurovascular structures consists of myelinated and unmyelinated nerve fibers and vascular capillaries. ده في الناس النورمال، بس ولا anomalous neurovascular structures in the enthesis of patients with congenital nystagmus. Sensory innervation of extraocular muscles. Sensory or proprioceptive receptors are found at the proximal and the distal ends of the extraocular muscle tendons. يعني عند tendon-scleral insertion وعند الديستال بارت بتاعت الاكسترا اوكيولار ماسل تندون اللي هي عند المايوتندينيوس جانكشن. المايوتندينيوس جانكشن بتبقى في الميديا ريكتس around 4 ملم من الانسرشن عشان طول التندون حوالي 4 ملم، واللاترال ريكتس طول التندون 8 ملم، فهي بتبقى بعد ال 8 ملم دي على طول. لقوا في المكانين دول في السنسوري or the proprioceptive receptors بتوع الاكسترا اوكيولار ماسلز. The proprioceptive neurons provide feedback allowing continuous calibration, alignment and stabilization of the eyes. يبقى هم دول مسؤولين ان العينين تبقى ثابته. And the proprioceptive neurons are also responsible for gaze holding and gaze shifting. يعني العينين تبقى ثابته او العينين تتحرك. Modified extraocular muscle proprioception has been proposed as a factor in the etiology and treatment of congenital nystagmus. يعني لو في مشكله في البروبريسبتيفز دول العيان ممكن يجيله nystagmus، ولو احنا عملنا disruption للبروبريسبتيفز دول ممكن نعالج النستاجمس. So surgical disruption of these proprioceptive receptors would presumably dampen the nystagmus. يبقى احنا لو destroying البروبريسبتيف receptors احنا المفروض ان احنا هنقدر نقلل النستاجمس. في حاجة تانية لقوها إن there is idiosyncratic variation in the distribution of afferent fibers in the tendons where they can extend beyond the enthesis. يعني هم لقوهم مش بس عند tendon-scleral junction، لقوهم إن هم extend along the tendon for up to 3 ملم من الانسرشن. فهو قبل كده كان الاندرسون بروسيدير ان هم بيعملوا ريسيشن وخلاص، فاحنا النيو موديفيكيشن اللي احنا قلنا نعملها ان احنا نريسكت الفيرست 3 ملم من المسل بحيث ان احنا نشيل البروبريسبتيف فايبرز اللي موجودين عند الانسرشن. So if there is idiosyncratic variation in the distribution of afferent fibers in the tendons, مش عند الانثيسيس بس, the new modification would be a complete excision or resection of the distal 3 millimeters of the tendon اللي احنا هنعمله resection. So we apply sutures 3 millimeters from the insertion, مش عند الانسرشن. بعدين we excise or resect the distal 3 millimeters of the tendon وبعدين نعمل الريسيشن اللي احنا عايزينه بتاع الأندرسون's procedure. يبقى كأن combining resection مع recession. So in nystagmus with an abnormal head posture or a null zone, we perform distal 3 millimeters resection of the tendon plus recession of the yoke muscles اللي هي Anderson procedure العادي. This is the modified Anderson's procedure that we proposed. So the resection or the complete excision of the distal 3 millimeters of the tendon is performed to ensure removal of all proprioceptive neurons at the tendon enthesis and beyond it to dampen nystagmus. And the graded Anderson procedure, which is the recession of the yoke muscles, is performed to correct the abnormal head posture. So for this child, we would perform a right medial rectus recession with 3 millimeters distal resection, and a left lateral rectus recession with a 3 millimeters distal resection of the tendon. And did it work? We are performing a study in Abu Rish, a thesis in Abu Rish, to compare graded Anderson العادي versus graded Anderson plus resecting the distal 3 millimeters of the recessed muscles اللي هو modified Anderson, assuming that these contain the proprioceptive fibers. And we evaluate the head posture, the nystagmus intensity, clinically and by video nystagmography, and visual acuity. And so far the results احنا عندنا two groups الأندرسون العادي والأندرسون مع resection. The results are variable. يعني we have successes, we have failures, and they are more or less similar in both groups. بس احنا we did only 21 patients so far. Still a lot to go to get a conclusive answer. So if the modified Anderson procedure is of extra benefit or not, I still don't know. Thank you very much.